This is the integrity recording for your Horntvedt Chapter 18, Lifespan Considerations in Dosage Calculations. So on this first slide here we have some objectives that are identified and reflected on Exam 2 for exam items that correlate to this material. We've got some general considerations here on these first slides that you can review. It is a nice overview of why we need to be especially cognitive, that we are ensuring safety and correct medication dosage when we look at pediatrics, because there are different alterations to their organ systems that put them at a higher risk for having a complication related to medication administration. So we see a lot of times that children will be given medications based on their body weight. And so the example that we have here is a provider ordering a medication, 0.15 milligrams per kilogram via IV route, 30 minutes prior to chemotherapy. The child's weight is 23 kilograms, and so we need to figure out, as the nurse that's taking care of this child today, how many milligrams we would administer, and we are going to round to the nearest tenth. So we would set up using dimensional analysis. I'm going to get my little pointer out here, and we are going to always start by identifying what we're looking for. And so here we are looking for milligrams. When we look up to our problem and what we're given for information, our provider has ordered 0.15 milligrams per kilogram. Now, we know that we're looking for milligrams, so that means we have to start out our first equation with milligrams as the numerator, or that top number. Since the provider has said 0.15 milligrams per kilogram, we have to keep that together in an equation here. Just like the per sign is causing this to be one equation, the way that the healthcare provider ordered it, we have to have those numbers represented in the same equation. Since we have kilograms down here and we're not looking for kilograms in our answer, that's one way that we can identify that that is something that we need to eliminate. And the only way to eliminate a label is to put it up here opposite, and then they will cross each other out. Sometimes students will put the X here to identify that they're solving for X, or other students will even put just the number 1 here, and that helps them to put it into their calculator and make a little bit more sense to them. So we've gotten rid of our kilograms, and then we're left with that milligram label, which is perfect because that's what we're looking for. So you would just take your calculator, and 0.15 times 23 then is 3.45. When we look at our instructions to round to the nearest tenth, or that first decimal, we would, actually here's an error in the book, folks. We would be rounding to 3.5 because this is 5 or greater. So your answer would not be 3.4, your answer would be 3.5. You guys will see, if you've been following along with my lectures, there are definitely some errors in the book. And so if you find any other ones on practice worksheets, just let me know. I've caught some of them, but clearly not all of them. All right, so here we've got another example, and if you want to challenge yourself and cover up the answer to this, or the rationale, you go ahead and do that, and then see if you can come up with the same answer. All right, so let's look at this third example. The pharmacy is sending diphenhydramine, or Benadryl, and it was a order in example 2. So we took the weight from example 1 and we figured out how many milligrams to give, and then we are now going to figure out how many milliliters we're going to administer of diphenhydramine. So let's look, and our pharmacy sends us a vial with 50 milligrams per milliliter, and we need to know how many milliliters we're going to draw up in our syringe. And so we've got the syringe in front of us. We know we're looking for milliliters. So we've got milliliters here, and so we start out, we have to have milliliters up here since that's what we're solving for. That's always going to be where we start with our numerator. When we look at what's available to us from pharmacy, we have 50 milligrams per milliliter. That has to stay together. The pharmaceutical company calculated and formulated that drug to be that specific concentration, so that has to stay together. Whoops, excuse me. So here we've got that all identified in one equation. And then if we look at this last example, if you completed example 2, this was the number that you received, how many milligrams. So here's our concentration, and then we're going to add in our number of milligrams from example 2. And you would take then 38.8 divided by 50, and we would round to the nearest hundredth per our rounding instructions. Sorry, this laser is just out of control here. And so we've got 0.78. The reason I wanted to do example 3 with you is to just think about that volume in your head. We have less than a milliliter. So you would definitely not grab a 10 milliliter syringe, a 5 milliliter syringe, or even a 3 milliliter syringe, because you're not going to be able to draw up the medication as accurately. So you would want to get a TB syringe or a 1 milliliter syringe. And you know, you're giving this IV, and even if there's a needle on that TB syringe, you can put a different needle on it to draw it up, because that smaller barrel of the syringe will allow you much greater accuracy. We want to make sure that we give that pediatric client the most accurate dose that we possibly can. And we've got another example here. So let's go on, and we're going to talk a little bit more about dosages. And so sometimes your provider will say that they want 4 doses per day. And so you need to be careful when you interpret that the provider is meaning 4 doses spread equally throughout the 24 hours. So that would not be every 4 hours, that would be every 6 hours then. If your provider orders 1 dose every 8 hours, that wouldn't mean that you're giving, you know, one dose 8 times. That would mean you're giving that dose 3 times equally dispersed throughout the day. And so a lot of times if you're at a bigger hospital, your pharmacy will help with this aspect, but it's just really important that we don't give the pediatric client especially more medication than was desired or ordered by the healthcare provider. Here's some practice problems, and I will be uploading the rationale to these practice problems hopefully before this weekend, but if not this weekend, it'll get done. When we look at dosages based on body surface area, we look and work these out the exact same way that you guys had learned in Chapter 11. So it's the same formula. It's sometimes preferred to use body surface area because it will reflect the more specific body size of the client rather than just using the weight. So a lot of times you will see providers using body surface area for children. So let's just do a brief overview and review from Chapter 11. So we have 7.1 kilograms and the child is 45 centimeters in height. Our instructions are to round the final answer to the nearest 100th meter squared. Now, a lot of students struggled with this part of the Chapter 11 quiz. We went through it in the Chapter 11 integrity, but I think it was still confusing to students. You always are going to round this meters squared number to the 100th. This gives you the most accurate dose. When the problem tells you to round to the nearest 10th, they are meaning the final volume or the final product. But when you have meters squared, you always should have this rounded to the 100th place. So let's look at our problem. We have kilograms and centimeters, and so that means that we are going to use that common divisional factor of 3600. I remember this, again, the clients, or a lot of times around the world, they use metric, and metric would be centimeters and kilograms, and so around the world can be represented with 360 degrees, and so you do have to add the extra 0, but this is how I remember that it's 3600. So you would just simply take 7.1 times 45 divided by 3600, and you get this number here, and we need to take the square root of that number. Here's the square root of that number, and here again we have the book not following their own instructions. So we have identified this needs to be rounded to the nearest 100th. So I want you to look and what would be, this would be counted wrong, and what would we have as our answer to this question? Okay. Why did the book not round to the nearest 100th, even though they said to round to the nearest 100th? Answer being, when you look at this third place here, it's 7, and so then that had us round up. I do have these quizzes set up so that if you left this larger number after you push the squared root button into your calculator, there may be a difference of 1/10 of a mil that will be accepted on these exam or these quiz items. But that's why when you look at this final answer, it is only to the tenths place and not to the hundredths place. So I guess when I set up here, always, 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 your one instance would be the instance of this first example. Okay, so our provider orders this medication 20 milligrams per meter squared, IM every 6 hours for the client that we just figured out the body surface area on. So now we're working and we need to figure out how many milligrams we're going to administer. So we're looking and we're working out milligrams, so we're going to identify milligrams here. We know that then we have to have milligrams here, and so ideally here, this 20, there should be a line here. So we have 20 milligrams per meter squared, and when we look at our answer, we're not looking for meter squared in the answer, so we've got to figure out a way to get rid of meter squared, and it kind of clues us and says the child from example 1. So I'm going to scroll back to example 1, and we had 0.3 meters squared. So here's where we will enter that information. Again, you could put your imaginary x down here if that helps you to make sure that your 0.3 is recognized as the numerator or the top number. So you would just simply take 20 times 0.3. Again, this comes out to an even number, and so even though your question instructions tell you to round to the nearest 10th milligram, we never ever put a trailing 0. So you would never on your quiz write 6.0 milligrams because the rounding instruction said to the nearest 10th. That does not apply, absolutely not. The only time that would apply is if you had a number that had, 6.11115. Then you would round to this tenths place. But otherwise, you're never going to add that 0 just to add a place. Those are just your general rounding instructions should that be needed. So now let's look at the volume of this medication. So we've decided in the first problem what the body surface area is. Second part, we decided how many milligrams to give. And now we've got this bottle of medication in front of us, and we've got to figure out how many milliliters to draw up. The medication tells us that there's 3 milligrams per milliliter. So again, we're sitting here with a syringe thinking, gosh, how much medication do I give? We're looking for milliliters. So we're going to always put our label here. This is what I write first. I always start out with milliliters. I make my line, and then I go up to my problem. And then I see here that 1 milliliter equals 3 milligrams. They're married in the problem, so they've got to be married down here. I know that the 1 goes on top because that's how it is in the problem, and that's what's with my milliliters, and then over 3 milligrams. Again, I'm not looking for milligrams in my answer, so that's kind of my cue that I've got to somehow eliminate the milligrams here. And when I look at example 2, I had identified 6 milligrams here. So let's go ahead, and then we would take 6 divided by 3, and our answer is 2 milliliters. Here's where I want you to critically think. If you would have gotten an answer of 200 milliliters, do you think that would be a normal, reasonable volume to administer to your pediatric client who weighs 7.1 kilograms? This is a very small child. No. And so use that critical thinking to interpret and to decipher, yes, 2 milliliters is a reasonable dosage, absolutely. All right, so here's some practice problems. Again, the answers to those will be posted. When we look at different ways that we can safely administer medications or fluids to pediatric clients, it's important to note that your general tubing that you'll use on a medical or a surgical floor is designed to rapidly administer fluids to your client that maybe is in hypovolemic shock or needs some type of a bolus. And so if you would just put your tubing at a wide open rate, you could easily give a liter of fluid to a client in about an hour, if not even faster. And so when we look at administering to pediatric clients, there's a couple of different ways that we can ensure to prevent fluid overload in that pediatric client. And so there's 3 of them listed, and we're going to talk about each of them in a little bit. And oftentimes we will see all 3 of these implemented together because this is a very, very safe way to make sure that we're preventing any possibility of fluid overload. So an infusion pump would be used. This would mean a special IV pump for a pediatric patient. We would not just be using gravity tubing and hoping that we have our drip rate selected correctly. Microbore tubing is a tubing that drips a smaller amount of fluid, and the amount of pressure on the bag doesn't necessarily affect how fast the drip goes. And so this is important because it will also prevent that rapid infusion of fluid should the manual control be set improperly. And then a volume control set, most often in this area I've learned or seen used the Buritrol, and we're going to talk about that. It's just another little safety device. So infusion pumps, a lot of times for pediatric use, they will be designated. It might be a syringe pump if you're giving a medication, but they don't have as much of a pressure, and so they will not have as much pressure exerted or force to try to maybe overcome a small occlusion at the end of an IV or something like that. And so we want that lower pressure. We don't want too much pressure because that could cause a infiltration of that IV, and we need to be very careful for that in the pediatric client. Again, this just highlights we don't want to ever be using a manual control of fluids unless the nurse is just one-on-one with that client right at the bedside, because it's too easy to have that set wrong or to get distracted and forget to come back, and then all of a sudden you've got a client that is in a fluid overload state. So our second way would be to use this micro drip tubing, and this is more drops per milliliter, and so we can't give as much fluid as rapidly, and so it is another second safety feature, and this is absolutely what you would use if you would be in a circumstance where you would need to do IV fluids under a manual control. If you just did not have a pump available, this would be one safety device you would absolutely implement. And then the third device is what I've seen most common around here. We use the Buritrol brand, and I'm going to go to the next page to show you a little picture. So what you do is, this is what goes into your IV bag here. So this is spiked into your IV bag, and then this is the actual Buritrol or whatever the brand name is. So what you could do is you squeeze this together, just like when you prime your pump tubing, you squeeze your drip chamber. You would squeeze this Buritrol section here, and say you were going to give a medication and you only were going to give, or let's talk about IV fluids. So you can see here the maximum amount of IV fluids you can fill with is 50. So let's pretend that this client every hour is getting 20 milliliters of fluid. What you would do is you could maybe fill up to 25 in your Buritrol, and then what you would do is close this roller clamp. And that ensures that should something go wrong, should you not get called back to the room, that 1,000 milliliter bag of fluid is not going to be allowed to bolus your pediatric client. Once the medication in this Buritrol is done, your fluids will just stop dripping. And if you're on a pump, your pump will beep and tell you that there's an occlusion, and that's what we want. And so this is what's ensuring that we can not only watch the site of the pediatric clients closer, they're at higher risk for infiltration because of their tissues and because of their frequent mobility. And so usually standard of care would be every hour you're in checking on that IV site, especially your neonates, because they're unable to oftentimes tell us if they are having pain. Depending on what the illness is, they may not even be able to cry in response to the pain. So you're really in there every hour, and so then every hour you would refill up here with your fluids for the hour, check your IV site, make sure that there's no signs of infiltration or excavation or infection or anything like that. So this is that third safety device. All right, so when we look at how we control fluids in children, we want to make sure that we're not giving them too great of an amount of fluid in the 24 hours. This is nothing that you need to have memorized, for me at least, but this is a graph that you could refer to if you were wanting to better understand what the normal amount of fluids would be that a client needs. So when we look at these questions, I am not going to go through them question by question, but I just want you to understand that if you needed to have a resource to look at to understand the amount of fluids, you can look at a graph such as this that would be available, and you could figure out how many milliliters of fluid that client would need per day. And then sometimes your provider maybe would say that they want the client to receive 70% of whatever that daily fluid need is from IV fluids. So then once you know how many milliliters per day they require, you could just multiply that times 70%. Maybe the pediatric client is drinking a little bit, but not enough to fully maintain their circulatory needs. So we would, count that they'll maybe be able to drink 30%, but we still need to provide, the majority of fluids through the IV. So that would be an example of what that percentage would be. So I will let you work out those problems, and I'll also have the answers to these practice questions posted by this weekend. So let's move on to talking about just a little bit about pregnant and lactating women. And so we know that when the woman is pregnant or breastfeeding, the medications or fluids that she ingests definitely are reflected and passed on to that baby through either the placenta or through the breast milk. And so when we look at the use of medications, it's important to look at each medication specifically because they are transferred and their risk to the fetus or the baby is different depending on what classification they are. So anytime that you are working with a client and a new medication is prescribed or being considered, you can look up in Skyscape your pregnancy category here. And this kind of just talks about what the risk benefit would be. So a lot of time your category A is things that are, for the most part absolutely adequately safe. There's not been any evidence that these can harm the baby. So your vitamins and things like that. Your category B's have said that, no animal studies have said there's risk, but it's hard to say that there's absolutely no chance. There's no evidence to suggest that it has. Your category C, oftentimes we see, do the risks outweigh the benefits? So if you have a client, a lot of times your antidepressants will fall in this category. And so if you've got a mom that struggles with depression, you kind of look at the weight of, would this mom be more beneficial taking the antidepressant and continuing with the pregnancy or breastfeeding, or is she stable enough that she could come off of that medication? And for a lot of women, the answer is that no, the risk of coming off the medication is higher, and so it would be most beneficial for the mom to continue to take that medication. So that's something that the healthcare provider looks at with each client individually, and you as the nurse need to be aware of that, so that if a client, was receiving an order for something that was just absolutely a category D or X, that would be something you would want to clarify with the healthcare provider. The main two X categories that I think of are definitely Coumadin or warfarin, and then a lot of times we hear about the acne medication called Accutane, and that's a category X medication. That example, in fact, on the pill packets for that medication, there's a big pregnant woman on there with the red line through it. And so there's a lot of warnings on these medications also to help try to make sure that clients are aware when there are vast and major teratogenic effects of your category X's. So just kind of a little breakdown of those. And then same thing about lactation. If a mom ever has a question of medication safety during lactation, there are great resources available through a certified lactation consultant. And so they tend to have a book that has pretty much every medication in it, and then they would be who I would reach out to for increased education towards the mother on if that medication was safe to take while she's breastfeeding the baby. Alrighty, so that kind of concludes the part about pregnancy. Let's look now a little bit at aging adults. And so when we look at medications related to aging adults, we just need to really recognize that, that those organs aren't working as well as they used to. And so a lot of times medications aren't as absorbed as well, but then also they're not metabolized and excreted as well either. So they're staying in their body longer than they would have in a younger person. So sometimes the dose may be less absorbed, but other times it might be less excreted. And so sometimes with an elderly client, you'll see that their dosages, whether it be blood pressure medications or diabetes medications, really anything, will oftentimes need to be adjusted and calibrated to just best fit that client's needs. The elderly client does have a decreased total amount of body water and oftentimes an increased amount of total body fat. So this is exactly the opposite of the pediatric client. And so that affects the distribution of both types of fat and water soluble drugs as well. The other thing that we need to really be cognizant of when we look at the aging adult is that a lot of times they're on a lot of medications, and they might not only be prescription drugs but also the over-the-counter things for arthritis pain or herbal supplements, and so the chance of them having an interaction between their multiple medications that they take is very high. So it's really important to get a good picture when you're admitting any type of a client, not only on their prescription medications but also their over-the-counter or their herbal or dietary supplements that they're taking. Here's a graph that just shows us a little bit about how those kidneys aren't quite filtering things as well as they used to. That liver has a decreased blood flow, so they have a decreased metabolism of the drugs, and it's kind of a combination of all the body systems that affect the way that that older adult client processes medications. So when we look at those, we do want to make sure that the medications are not accumulating in the client's system because of that poor kidney function and becoming toxic. So we're really carefully monitoring the elderly client and adjusting dosages as needed. That concludes the Integrity presentation for Chapter 18. So let me know if you have any questions. Have a great rest of the day.